Good morning, good afternoon, good evening, depending on where you are in the world. Welcome to this 3D conversation. I'm Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health in Boston, United States. I am hosting this conversation and this series of conversations in my capacity as chair of the Rockefeller Boston University 3D Commission. The 3D Commission is a commission that was started about 2 years ago, and with the 3 Ds in mind, the Ds being data, determinants, and decision-making. The vision behind the commission was to bring a group of world thought leaders on the question of how do we better measure social determinants so that we can make better decisions for health, hence the 3D data, determinants, and decision-making. The inspiration behind the commission was the observation that the social determinants agenda has really grown over the past 25 years, and that there is increasing attention being paid to how we should incorporate social determinants in our thinking as we make decisions for health. The challenge oftentimes is that the data that we have available is not available to characterize the social determinants well enough, despite the fact that we've had a growth in big data and growth in data resources available. We established the commission in 2019, which is the relevance of that is that it was before COVID ever hit the world, before any of us had ever heard about COVID. And then the commission really unfolded all during the time of COVID, which, as you can imagine, changed the tenor of the conversation and changed the focus of our thinking, at least sharpened the focus of our thinking. The commission's final report will be released next week at the UN General Assembly meeting, and anybody who's on here is welcome to attend that. And we've been sending out announcements of the link for that. It will be done on Zoom, just like this. And the final report includes sets of principles and recommendations around how, throughout all countries in the world, we can inject better measurement of social determinants, create the structures that support the assessment of social determinants, so that political and policy decision-making takes into account social determinants that are measurable, resulting in accountability to the health of populations. That's fundamentally has been the arc of the commission. As we're heading closer to the launch of the report, we have been hosting a series of conversations. This is our 5th one that we're doing with eminent thought leaders to reflect a little bit on the agenda of the commission. Not necessarily only about the report itself, although the conversations are with people who have the report in hand, but really with the broader agenda of how do we better understand social determinants of health so that we can make better decisions to create better health for populations worldwide. So with that in mind, I'm going to move to today's conversation. It really is a great honor to welcome Professor Sundari Ravindran today with us for this conversation. Professor Ravindran is a principal visiting fellow at the United Nations University International Institute for Global Health. Professor Ravindran has a PhD in applied economics, and her research interests include inequities in health with a focus on gender-based inequities, sexual and reproductive health and rights, the political economy of health, and health systems research. She has been an activist and a trainer working at the local and international level for close to 4 decades. She's a founding member of both Common Health, a National Coalition for Reproductive Health and Safe Abortion in India, and Rural Women's Social Education Center, a grassroots women's health organization in Tamil Nadu. Professor Ravindran, it's really an honor to have you with us today. Thank you for joining us.
Thank you for this opportunity to participate in this conversation, Professor Galea.
So as Professor Ravindran and I were talking ahead of this call, we have a lot of questions that I can pose to Professor Ravindran. So I'll start with a very general one, and we'll see where it takes us. Can you, Professor Ravindran, reflect on the need for data to capture the conditions of where we live, where we work, where we play, the world around us, social and economic conditions that ultimately shape our health, through the lens of where you live, through the lens of Kerala, India, Asia more broadly, and how you see the evolution of those ideas in your region?
Well, the need for data. One of the things that we see is that when we look at and when we try to understand the reality around us, one thing is to just base yourself on lived reality and observation. But in order to really get a grasp of the dimensions of this problem, of any problem, you need broader data on how various factors, one of like one's gender, one's caste, ethnicity, where one lives and what one has access to makes a difference to the resources you can access to remain, to be healthy and to prevent illness and to access healthcare when it is needed. 3D Commission seems to talk a lot about the intersection of data, determinants, and decision making. And one of my concerns has been that each of these pose major challenges. Say for data, I won't even go to the big data issues, even in traditional data collection. What worries me is that, say, even in terms of health outcomes, there is very limited data on many health outcomes beyond morbidity and mortality. When you come to social determinants of health data, it's collected differently in very often in parallel streams, and also mostly on the material conditions of life and not on the behavioral and psychosocial and so on. When we come to the decision making, there is already, there is not a ethos of decision making on the basis of data. For example, frontline workers in many of our primary health centers collect loads and tons of data, and they send it up the stream. It's collected, the primary health center's medical officer sends it to the district sends it to the state, and then the data is tabulated and produced. But it's never used for decision making at the local level where it would be most useful. The other and more concerning aspect of decision making using data is that very often it could be used punitively. And therefore, the veracity of the data itself could be compromised, because if I report, I may be at risk of being penalized because I'm seen to have failed in my duty, which also comes out of a lack of understanding that there are many social determinants rather than just delivery of healthcare services that affect health outcomes in any particular area. And also decision-making is affected by lack of appreciation at the policy level. So our policies, our health policy has has not prioritized addressing health inequities. And it's all about averages and achievement of averages. And once that happens, there is very little incentive. You're only looking at the totals and the marginalized groups and the depth of the ill health and so on could remain unappreciated. So where I'm coming from, I find that it's very important, but it's a very challenging task. It seems daunting to me how we would address each one of these issues. So,
well, that was really interesting. So I really resonate with your notion that you said about there isn't an ethos of using data to guide decisions, and I think you very well articulated how data are available, multiple levels, and they sort of flow up, but we don't use them. So can I ask you to look back a little bit, let's say 25 years, and how have we done? Like have we progressed? I'm just trying to push both on that ethos, on this ethos of data for decision making, and also on our understanding of the range of social and economic determinants that affect health. How do you've been involved in some of the key seminal global events that I think have really catalyzed social determinants thinking. I'm just wondering how you look back over 25 years and where we were then, where we are now, and perhaps the hardest question is, are we where you thought we'd be? Are we better? Are we worse?
I would say we have made a lot of progress, not in use of data for decision making, but in a better understanding of the importance of social determinants of health for health outcomes. There is much more appreciation of this, not only globally, but also within countries and even at the local levels. But I think there's a lot of more scope for improvement on 2 or 3, and you'll find me repeating this again and again. I think not enough has been done to appreciate the contribution of gender-based inequities in society and how that mediates social determinants of health to affect health outcomes. There's a lot of work going on addressing gender inequities in health, and there's a lot of work going on SDH. And conceptual advances have also been made, but these very often, there are exceptions, but very often are developing parallelly. And the other area where I think more could be done is that we seem to know much more now about what are the issues, but not in terms of what are the gaps and how big are these gaps and how they are, by sex or race or class and so on. But why are these gaps there? What are the pathways through which these gaps get, created and then sustained? I don't think we know enough. We know they are mediated by material conditions and behavioral aspects and so on. But since these vary by context, we don't know enough about, which kind of interventions. Unless we know why there is that gap, we are not going to be able to make suitable, appropriate interventions. And, we keep saying SDOH approach is so that we will not have a one size fits all. But that means in that area, I think we need much more work. The third thing that I think is that we've done a lot advocating to recognize the importance of SDOH, and I think that has paid off. But what are the next steps? How do we then make sure that it's implemented? Okay, policymakers have agreed that we need data on social determinants of health, and we managed to get data. There's a commitment. What do we do with this data? How does planning take place for health, and at what level, so that this approach can be actually implemented? What are some of the best practices at scale? There are a lot of case studies that have been produced. I don't deny that. But what about implementation at scale, at the country level, at the provincial level? How much do we know about that? And I feel that we need to do much more in these areas.
I think the distinction that you make between our progress in understanding the social determinants versus our progress or lack thereof in injecting social determinants thinking, decision making is a really important distinction, because I tend to share that. I do think we've made enormous progress in the past 25 years in our science, in our scholarship, in our conversation, and I find that there is a social determinants conversation that's active now in public sectors and private sectors. But I think you correctly point out that that has not yet translated into that becoming intertwined with an action agenda. And that's an important distinction, because I think it points to where we need to go next. So thank you for actually elucidating. So let me build on that for a second, and maybe I can ask you to lean a little bit on areas where you've made really important contributions, and particularly thinking of gender as social determinant and issues around reproductive health. Can you talk a little bit about, through that lens now, through the lens that you know so well, the data gaps in our understanding and the decision-making gaps that would be needed to actually truly improve reproductive health and women's health if it were better informed by data?
So I think there can be no other area that illustrates better that information and evidence is not enough to make decision makers take action. Gender, because there's so much evidence now about how, unless you account for gender-based differences, and you pay attention to how that affects not only gender, but biological, sex and gender-based differences, how they affect each step of the way, from risk and vulnerability to health-seeking behavior and so on. It affects, health outcomes will not be optimal. There is and tons of, evidence on this. However, and these remain, and sex disaggregated data collection on a national scale continues to remain a challenge, because it seems like decision makers are not convinced that adding one more axis, it will double anything, each indicator, you will have double the volume of data. Is it worth the investment is, I guess, one of the questions they have. And UN Women has been tracking, how many countries have data disaggregated by sex for the SDG gender-specific indicators. And they say that out of 53 gender-specific indicators of SDG, only 12 have regular sex disaggregated data available. And that in many countries, it is not yet people have not, decision makers have not bought into this idea or the importance of doing this. And so again, the other, it's not only gender, but it's the intersectional gender lens that is to understand that not all women and all, are less privileged than all men, and there could be groups of men who are less privileged than groups of women, some groups of women, and all those layers. And so demanding data gets collected by additional axes, beyond sex, is going to be even more difficult. And when you look at some of the reasons maybe why, again, it's in the field of gender that much work has been done about how organizations are gendered, how systems are gendered, and so, and you can extend it to look at how, a certain lens becomes difficult to apply when, there is a routine way of doing business, which, for example, in terms of data, who collects data, who decides what the indicators are on which data has to be collected. Each of these is going to affect what is considered important to collect. So I think that's been a long, it's a long and ongoing battle for many people, that you get a buy-in. Yes, gender is important, everybody agrees, but then do you then move on to collect sex disaggregated data? And then if that is done, do you then start programming in such a way that you account for those differentials when planning interventions, saying that the pathways and risk factors are different for different groups of women and men, and so on. So,
well, you raised some really excellent issues. So let me just try to tease some things apart, because I think the example of sex disaggregating data, and you said something which I thought was very straightforward, but actually very profound, which is, well, you sex disaggregate it, all of a sudden you have twice as much data, and which obviously is a mathematical observation, but I think it's actually quite important to highlight that, because it really highlights how once you start looking at data by these dimensions, now you're creating more data. And one of the things that we grappled with in the commission is the fact that many people, good intentions, who are in a position to make decisions, who have authority over resources, are not equipped to actually handle data, to actually have data analyzed, to take raw data from noise to create signal that can adequately inform decision making. And we talk in the report about the need for establishing structures at the regional, national level that can allow analysis of data to meaningfully inform policy, because in some respects, otherwise it's sort of just empty words. And so I thought your notion that you sex disaggregate data, you instantly have twice as much data, meaning it becomes twice as hard to actually wrap your brain around it, it's a very interesting one. So having said that, let's talk a little bit about the challenges with action on data, particularly. Let's just stick for a second with issues of reproductive health and women's health in particular. Can you talk about where you've seen progress? Can you talk about where you've seen progress and the role that you've seen data play in that progress? And I suppose I would love to hear that as a way of trying to learn from that and to say, how is that generalizable to other areas of concern, other areas, substantive areas of concern, and other geographic areas of concern?
Actually, reproductive health or sexual and reproductive health is one of the more challenging areas on which to collect accurate data, because these are sensitive issues. So the challenges become that much more that even, collecting data from surveys and so on, you won't get accurate reporting. Women and men may not want to report on sexual activity or abortions or, issues like that. So in terms of where progress has been made, the sexual and reproductive health community has won many, has managed to make sure that it's very much part of the SDG agenda, and some indicators on sexual and reproductive health are included as part of the SDG indicators. However, again, most of the indicators on which data are available and are therefore tabulated, and you see on the SDG dashboard, have to do with maternal health and family planning. Because I think there are many reasons for this. And one of the major things is that these have been very important for policymakers for a very long time. And, so maternal mortality ratios and, service use in terms of institutional deliveries and antenatal care, family planning use, and fertility or adolescent fertility. These have remained the only kind of indicators on which data are widely collected, and huge areas and invisible populations. For example, transgender populations are nowhere in the data. But also, if you go by major sources of data like demographic and health surveys, in many countries, especially in Asia, the data is collected on married women of reproductive age. So if you're a single woman and you're beyond reproductive age, you figure nowhere and you are rendered invisible. So there are, you gain some, but you have to push, you have to go much farther. And there is a need for data on many other aspects of sexual health and reproductive health, which are not available. And in fact, activists are pushing for data that would capture sexual and reproductive rights, in the sense that are they fully informed when they get contraception? Are they, is there informed consent for various procedures? Is there disrespect and abuse in maternal health service delivery, and so on? So there is, demand for more data that's still ongoing.
That's really interesting, actually. Can you talk about, as you were speaking, I was thinking about the COVID moment and and how much it has challenged much of what we do in multiple aspects. Can you just talk a little bit about, in your sphere, and I mean that both in terms of area of focus, but also geographic, how COVID has complicated things and or not, or maybe not. Maybe it's made some things easier. I'm just wondering your lens on sort of the COVID moment of the past year and a half, and the challenges it presented and the opportunities it may also present.
Let me, I think the audience and all of you are very aware of the very, very difficult times that this country went through because of COVID, and especially the second wave of COVID. So I'm not going into that aspect. What I would like to talk about is the opportunities that it has provided. First of all, it has established and highlighted beyond a doubt that social determinants of health matter. This pandemic has affected the most marginalized groups, and it's observable. You can see how people have been affected, their livelihoods have been affected, their educational inequalities are widening because of the online schooling, food insecurity has widened. There's a lot of data being collected on how gender-based violence has become more pronounced because of being cooped up within the house, and the male presence in the house, and a controlling presence within the house. So I think it has given people the opportunity to appreciate that it matters. And it's very important to pay attention to social determinants of health. And I think this is also the moment where I think we have to act to point out that the long-term impact of all the social determinants are going to affect health for a very long time to come. Not only because COVID, is expected or predicted to recur on a, annual basis, at least in pockets and so on, but in affecting population health overall because of lost opportunities in education, livelihood, food insecurities, the undernutrition that may have set in at this time, the problems of newborns during COVID times, and so on. So I think this is the time to strike, and also probably using data and analysis to show what impact we would have if we paid attention to those positive externalities, in making sure, that health improvements 20 years, 10, 20, 30 years down the line are at a different place. It doesn't have to be, stagnant or worsen, if only we paid attention to specifics. That said, again, there is gender blindness in COVID data that has been documented, that many countries, apparently only 1 in 3 countries are sex disaggregating COVID data. So while we know that migrants are being affected, particular marginalized groups are being affected, we don't have a grasp of whether the higher mortality among men observed overall is true across the board in all these substrata, for example, and whether, and that could affect the way we approach this. So,
well, I really appreciate your answer around the opportunities that are presented by COVID, because I agree with you completely that nothing ever redeems a tragedy like COVID. Nothing redeems the loss of life and that come with an event like this. But I do think that we have a responsibility to say, how can we extract good for the future from it? And I agree with you that one of the positives that we should be extracting from the moment is a sharpening of our collective recognition of the importance of these social determinants. And COVID, of course, did not create health inequities on multiple dimensions, but it made them clear to everybody, which is actually critical. Let me ask a question about, you've done a lot of work with grassroots organization in the advocacy space. And one of the things that the Commission discussed quite a bit were notions of data democracy and of ownership of data by communities and accountability to communities for decisions built on data. And that's why I was just wondering if you can reflect a bit on that, and maybe colored through COVID or maybe not, but just as the broader agenda, because I know that's something that you've thought about.
Yes, absolutely. I would say that, I mean, you introduced me as being a founder member of a grassroots women's organization, and that organization is 40 years old now. And from the very beginning, the organization works with Dalit women who are actually leading the organization. One of our main focus has been that the community level health workers or community activists understand and are able to apply data to, think about what needs to change. So they've been part of data collection, can community groups really be involved in understanding complex data? Not everybody can, I agree, but there's always data buffs, even in high school educated, from those who are just high school educated and are not data scientists, who appreciate and who value understanding, and information is power. The moment they know that 2/3 of the women who had a reproductive tract infection never did anything about it, this was based on local data collection, it made a huge difference to saying, wow, why did they not do that? And why it's, what are the barriers? How can we help each other do something about it? And so on. So I think it is very important. Also, the other organization, it's a network, the Common Health Network, carried out a very interesting exercise called Dead Women Talking. It was collection of data on maternal deaths by more than 30 plus local groups, and collation of this information all together to see patterns of who was really dying, what were the extenuating circumstances, and so on. I think I see hope also because in the context of SDGs, people have begun to talk about citizen-generated data as working, the role for CGDs. And again, guidelines have been produced by UN Women, for example, about how civil society organizations can engage with statistical offices at the provincial and national level to provide meaningful and supplementary or complementary information, not just quantitative data. So I think there is scope to move that agenda forward. And in fact, that was going to be one of my asks for the 3D Commission to take that work forward through experimentation in Hello?
Yes, you're back. You froze for a second. You
I
froze
did.
Through experimentation. That's where you froze.
Yeah, but that's all I said.
Okay, good. All right, perfect.
Yeah.
Let me change the question for a second and ask perhaps a slightly more personal question, but builds a little bit on what we were just saying on your history. We have students who are listening and who will watch this afterwards. So I think there are a lot of people who will tune into this who really admire what you've done, as I have over the years. And I was wondering if you could offer a bit of a personal reflection about what were milestones for you in your career that led you to the contributions you've made and to who you are today, looking back on it at this point.
That's actually one of the more difficult questions.
I'm sorry, yes, I realize that.
But all I can say is that it was my work in the very early stages of my life, meaning in my early 20s with Dalit women in Tamil Nadu, that opened my eyes to the social determinants of health and to the contribution of casteism and sexism to poor health outcomes. And so, having learned that from the ground, it remains an unshakable kind of, guide in my life, saying that we have to deal with gender-based and caste-based discrimination if we have to get anywhere because that with improving health and well-being of people. I have had the I would say I have been fortunate and have had opportunities to work at the grassroots, but also at the international level. It was just providence. I don't think I did anything in particular too. So I did work in spells with WHO in Geneva on gender and health issues, on maternal health issues. And suddenly, understood things on a wider scale. I then went on to teach who were doing masters in public health course, where I taught for several years. And I've also been associated with the journal Sexual and Reproductive Health Matters, of which I was one of the founding co-editors, and now I'm one of the senior editors. So I guess, and my training in economics, applied economics, all come together somehow to help me understand the interlinkages. And my training in applied economics was more from a political economy lens. And therefore it made it much more easy. It's somewhat easier for me to see connections. So that lens always helps me to see connections between the grassroots and the macro and the global. So
thank you. That's
there was one thing that I wanted to there was one thing that I wanted to mention, that in the beginning I had said that more could be done in terms of making social determinants of health, operationalizing it on the ground. And in that context, I wanted to share a thought with you. What I'm seeing in Kerala, which has decentralized governance, but also in terms of real devolution of power and budget at the village government level, I see that the health standing committees of village governments are much more able to view health holistically and not only as health service delivery. And one of my students was doing some work on innovations in primary health care. And I saw village governments develop waste management programs, vegetable gardens, physical activity programs. So a whole range of what you would call action, multi-sectoral action. And it made me wonder why, or whether, maybe I'm not aware of it, why more thought has not been given to the role of decentralized and empowered local governance for advancing the social determinants of health agenda. Because there, everything comes together. They are not separate departments. They are able to see the interconnections way better. So I just wanted to leave that thought with you.
No, that's actually really interesting. And we have had this conversation in the commission and in some of our writing about the potential of more local, smaller scale governance to actually bring bring to light and bring to reality action on social determinants, and in many respects that might be able to overcome some of the challenges that there are at larger scales and national scales, particularly because of the siloing of budgetary responsibilities at larger scales, which you can overcome on a shorter scale. I think that's a perfect setup actually to my last question. And as we wrap up, I really would like to ask you about an envisioned future, about an envisioned future. Sort of ask, to end by looking forward. So like picturing a time when some of these ideas, when the ideas that come from the activists, from the policymaker, from the research, the advocates about injecting data about social determinants to inform decision-making, when that becomes a reality, like what does that time look like? What becomes possible that is not possible now? How does that go towards and contribute towards building a healthier world?
I think to some extent I have already answered that question in the sense that one, that it's at the community level, the data has to be owned, understood, interpreted, and acted upon. And for that to happen, you need political power and the financial allocation power to make projects and interventions possible at local levels. And I think it's only then that it would be possible to improve health outcomes through a very holistic approach to the various determinants of health. And I think there is a tension between talking about, how social determinants are very context specific, and then talking about influencing national policymakers to work on social determinants of health, where it could become kind of one size fits all. Shall we work on employment, housing, something and something? Maybe very different in each context. And I guess we need the bottom up so that the top down does not, overwhelm the local needs and realities. So.
That's wonderful, and it strikes me as just right. And I like the notion of not overwhelming local needs and realities, and as part of an envisioned future. Well, you, Professor Ravindran, you get to have the last word. What charge do you have for the audience? What ask do you have of the audience? It's, with assuming that I think our audience is people who from different sectors are interested and committed to the idea of creating a healthier world. And what's your ask for all of us?
I guess to be aware and conscious that data is not neutral, that the decision on what data to collect, where, at what level, and so on, are political decisions, and that, to be aware of that. Am I freezing? Hello? Hello?
We can hear you. I think we're frozen on our end.
Okay.
But we can hear you.
Yeah, sure. So it's more, one is to be aware. In this era of big data, I think awareness that data is not neutral, and that all the, the inequities reflected in the health system and in the tech systems are going to influence the nature of the data, the nature of, and probably introduce biases in algorithms used and so on. To be aware of that, and not just be aware, but to work out ways of addressing that, because I see the potential of using, and I think it's the need of the day, of using data from multiple sources, multiple kinds of data, but always to be aware that it's not neutral, and that there could be biases inherent both in the data collected and in the way, in the modeling and so on, because of the inequalities already present in society that, make for underrepresentation of certain groups in leadership, among human resources, and even in the information that is generated. So that's one important ask.
Well,
yeah.
Professor Ravindran, that is an important ask. It's an important charge indeed. And I am so grateful to you for everything you've done. I have observed and learned and admired from you from afar. So it's been really a privilege to have this opportunity to have this conversation. And even we sustained it through dodgy Wi-Fi on both our ends. And I think my Wi-Fi just dropped and had to change seats to a place with good Wi-Fi. And but we persisted even through some technical limitations to have data transmitted across our lines.
Yes, we did. Yeah.
Thank you for taking the time. Thank you for the conversation. Thank you for everything you do. Everybody.
Thank you for your very